Hi everyone, my name is Matt. I'm a first year OBGYN resident at GW University in Washington, D.C. And today I'm going to be talking to you about multiple gestation, looking specifically at twin-twin transfusion syndrome. This is something that we don't really see all that much in general practice outside of MFM, but seems to come up with some frequency on CREOG review and TrueLearn questions. So hope is that after this talk, you'll be able to get those questions right. So, all twin pregnancies should undergo an transvaginal ultrasound sometime between 10 through 13 weeks gestation. This is looking at a number of things, but for the purposes of this talk, it's looking at chorionicity. And the reason for that is specifically between 10 through 13 weeks is when the placenta and amniotic sacs are best visualized. Identification of chorionicity helps guide antenatal surveillance, risk management during pregnancy, as well as informing the timing of delivery. Throw back to step one, you've got the lambda sign seen on ultrasound, which is indicative of di twins, so two placentas, two amniotic sacs, or the T sign, which is really just the absence of the lambda sign, which is indicative of monodi twins, so one placenta and two amniotic sacs. This here on the left is the lambda sign, and here on the right, the T sign, meaning one placenta. Jumping right into a prologue question. This question is talking about a 29-year-old at 20 weeks with monodi twins. It gives you a bunch of ultrasound findings, and really what this question boils down to is the diagnostic criteria for twin-twin transfusion syndrome. Twin-twin transfusion syndrome is something that's unique to monodi twins. Approximately 1/3 of all twin pregnancies are monozygotic. Approximately 3/4 of monozygotic twin pregnancies are monodi. Twin-twin transfusion complicates about 8 to 10% of monodi pregnancies and usually presents in the second trimester. It's believed to result from intertwin vascular connections within their shared placenta that leads to volume depletion in the quote-unquote donor twin, which manifests as oliguria and oligohydramnios, and volume overload in the quote-unquote recipient twin, manifesting as polyuria and polyhydramnios. So, going back to our question, diagnosis of twin-twin transfusion syndrome relies on two diagnostic criteria. One, a monodi twin pregnancy, and two, oligohydramnios in one twin as defined by an MVP of less than 2 centimeters, polyhydramnios in the other, as defined by an MVP of 8 centimeters. Quick reminder, when looking at fluid in twin pregnancies, you use MVP and not AFI. Other features that can be seen in twin-twin transfusion syndrome but are not themselves diagnostic include first trimester findings such as crown rump length discordance, nuchal translucency over the 95th percentile, and over a 20% twin discordance. At second trimester, you can start seeing AC discordance, membrane folding, filamentous placental cord insertion in the donor twin, as well as increased placental echogenicity in the donor portion of the shared placenta. You can also see fetal growth restriction, as well as abnormal umbilical artery Dopplers. Going back to this question, they throw things at you like 30% discordance, fetal growth restriction, but ultimately the thing that they were looking for was abnormal amniotic fluid levels with oligo in twin A with an MVP of 1.2 centimeters and poly in twin B with an MVP of 9.7 centimeters. Other things to know about twin-twin transfusion syndrome is that there's a staging system based on the ultrasound findings. Traditionally, it's been thought to correlate to prognosis. However, more recent evidence suggests that it's really the transition from one stage to the other that is related to outcomes. The mildest stage, stage 1, basically twin pregnancies that just meet criteria, so monodi twins with oligo in one twin and poly in the other. Stage 2, you start to see signs of more severe oligo in the donor twin, which manifests as an absent meaning an empty bladder on ultrasound. Stage 3, we start seeing abnormal Dopplers, including absent or reverse umbilical artery Dopplers, absent or reverse ductus venous flow, and a pulsatile umbilical vein. Stage 4 is defined by hydrops fetalis, and stage 5 defined by the death of one or both of the twins. Moving on to management, an important aspect for management of twin-twin transfusion syndrome is counseling, and really all monodi twin pregnancies should be counseled on the risks of the development of twin-twin transfusion syndrome, as well as what it means for antenatal surveillance and the different management options. Talking about monitoring, all twin-twin transfusion syndrome pregnancies should be screened for congenital heart disease. The disproportionate amount of blood flow in one twin and the other can lead to a lot of perinatal heart defects. And serial ultrasounds should be done every 2 weeks, starting at 16 weeks for all monodi twins. Reason for that is twin-twin transfusion syndrome is something that can develop very quickly, so regular follow-up is very important. Treatment options are really dependent on the severity of disease and what stage they're put into. For the more milder cases, expectant management is a very reasonable option, but when the disease becomes more severe, things such as amnio reduction, septostomy of the intertwin membrane to equilibrate fluid levels in the two twins, and then finally, probably most famously, fetoscopic laser photocoagulation. Moving on to prognosis of twin-twin transfusion syndrome, is it's really dependent on the severity of the disease. In the mildest case, stage 1, there's actually a pretty good perinatal survival rate without any intervention at all. However, 10 to 30% of stage 1 twin-twin transfusion syndromes do progress to a higher stage. Because of the success rate with expectant management, there isn't really that much evidence out there looking at the different interventions at this stage. The best studied one is amnio reduction, which showed regression in 20 to 30% of cases, but that's pretty similar to what we get with expectant management, so the risks of interventions at this stage really do outweigh any benefits that might be gained. Moving on to more severe cases, looking at stages 2 through 4, the mainstay of treatment in these cases is fetoscopic laser coagulation at less than 26-week gestation. However, this is not super well supported in the evidence. The biggest trial looking at twin-twin transfusion syndrome is the Eurofetus trial, which didn't actually show all that much of a benefit of fetoscopic laser coagulation, with a pretty high adverse events when undergoing interventions. When fetoscopic laser photocoagulation is not available, amnio reduction or expectant management is a very reasonable approach. Moving on to finally on stage 5, there isn't really any evidence out there supporting one intervention over the other. Unfortunately, the prognosis at this stage is pretty bleak. In the event of death of one of the twins, there's a 10% risk of death and 10 to 30% risk of neurologic complications in the surviving twin. Finally, this is a chart put out by the Society for Maternal Fetal Medicine that really just does a good job of summarizing everything I've talked about. And if you take away nothing else from this talk, just know that this chart exists and you can come back to it for all your twin-twin transfusion needs.